Глубоко уважаемые коллеги, давайте начнем продолжение нашей сессии, которая будет посвящена аспектам кардиореабилитации. Я хотел бы представить президиум, председателей. Это доктор медицинских наук, профессор Нановачкана Погосова, Кардиологический научный центр, город Москва. Профессор Франциско Лопез, клиника Мэйо, Соединенные Штаты Америки. Он у нас будет представлен онлайн, дистанционно. И, наконец, позволю себе представить себя я. Меня зовут Игорь Геннадьевич Никитин, доктор медицинских наук, профессор, заведующий кафедрой госпитальной терапии номер 2 лечебного факультета РНИМУ имени Пирогова и директор Федерального государственного автономного учреждения лечебно-реабилитационный центр России, Национальный медицинский исследовательский центр в части реабилитации. Насколько важна сегодняшняя сессия, буквально 2-3 слова я хотел бы сказать как ведущий. С точки зрения реабилитации, это чрезвычайно важнейшая часть медицинской науки, и тому мы видим в последнее время подтверждение. Мы очень много раньше акцентировали свое внимание на процессах, выполнения тех или иных клинических рекомендаций, строгих стандартов. Особенно это наглядно было видно в части оказания медицинской помощи больным с сосудистой патологией, в части неврологии, кардиологии. Но нам очень важно было оценить последствия наших действий и, так сказать, оценить эти результаты в процессе какого-то периода времени. Мы должны были сконцентрировать уже свое внимание на понимании, кому надо было и в каком объеме продолжать реабилитацию. С моей точки зрения, результативность таких подходов, это показывает международный опыт и опыт наших коллег. Он дает иногда совершенно удивительные результаты, когда человек возвращается в обычную жизнь, социализируется, и, так сказать, его утраченные функции в ряде случаев либо полностью восстановлены, либо позволяют ему достаточно комфортно существовать в той среде привычной, из которой он попал, так сказать, на больничную койку. С другой стороны, конечно же, клиническая реабилитология, она претерпевает в последнее время чрезвычайно интересное свое развитие, привносятся новые технологии, новые взгляды, она становится, может быть, где-то императивной, даже агрессивной. При этом я, как и вы тоже, наверное, человек, который работает, воспринимает факты и результаты с позиции доказательной медицины, мы с вами отчетливо понимаем, и это можем констатировать, что в реабилитации сейчас еще очень много качественных, описательных параметров, ориентироваться на которые достаточно сложно, говоря об эффективности того или иного метода, групп методов реабилитации и так далее. Поэтому, мне кажется, подобного рода встречи и подобного рода вот такой обмен опытом, он окажется чрезвычайно полезным с точки выработки и управленческих решений на уровне субъектов, на уровне государств и, конечно же, с точки зрения индивидуальных подходов к конкретному пациенту, Иванову Ивану Ивановичу. Поэтому я с большим удовольствием представляю сейчас еще и слово Нане Бачковне, и потом мы начнем наш симпозиум.
Уважаемые коллеги, Игорь Геннадьевич, большое спасибо за вступление, которое вы сделали, обозначили очень важные аспекты и подходы к кардиореабилитации. Мы сегодня будем иметь возможность слышать наших зарубежных коллег и поучаствовать в обсуждении этих докладов. Я должна от имени оргкомитета, уже не как сопредседатель, а от имени оргкомитета сделать одно короткое объявление. Дело в том, что профессор Амир Лерман, который является ведущим специалистом по сердечно-сосудистым заболеваниям клиники Мэйо, попросил оргкомитет нашей юбилейной конференции переставить его доклад на более позднее время, что мы и сделали, учитывая важность заслушивания его доклада и его обсуждения. Он сделал большую любезность, согласившись выйти онлайн для общения с нами, и поэтому мы несколько переставляем доклады. И первый доклад, это будет под названием «Будущее сердечно-сосудистого научного поиска». Именно профессор Лерман, я уже его представила, поэтому будьте добры, поставьте презентацию.
Hello, and thank you again for the opportunity to participate in this exciting program. I apologize for the fact that we are sharing this experience and able to communicate with friends and colleagues. This presentation will be focused on the future of cardiovascular research. In fact, some of this future of cardiovascular research is already here and was accelerated by the COVID-19 pandemic. We're in ability to see a lot of our patients in the case. I'm Amir Lerman, Professor of Medicine in the Department of Cardiovascular Disease at the Mayo Clinic and the Director of Cardiovascular. This is my disclosure slide relevant to the current presentation. This slide represents the incidence and the mortality from cardiovascular disease in the last 10 or 12 years. As you can see, in spite of our effort to reduce and advance in treatment, there is still high prevalence of cardiovascular disease, and they are still the major cause of morbidity and mortality in our society. It's also obvious that it's not a homogeneous event, and there are some populations that are more vulnerable and have disease than others, which emphasize our need to get to this patient the same degree that we see our patient in our clinic. This slide represents the 10 advances that were made and made modern cardiology, and we don't have to go over them, but just to remind you that the major innovations were the electrocardiogram, the cardiac catheterization, cardiac surgery, coronary angiography that was actually discovered by mistake and error, the establishment of the coronary intensive care unit, cardiovascular drug like beta blocker, ACE inhibitor, statin, preventive cardiology, cardiac imaging, and pacemaker and defibrillation. All of that reshape our modern cardiology. But in spite of that, in the shift of our population, cardiovascular disease remain the major cause for morbidity and mortality. If we look at technology and how these inventions were made in the past, usually it started with unmet patient need, hypertension, high cholesterol, coronary disease, and then technology was invented to resolve this unmet patient need. Things changed since 2007. I don't know if you all remember, but in 2007, a lot of technology that we use on a daily basis currently doesn't exist. Facebook didn't exist. Twitter was a sound. Cloud was in the sky. 4G was a parking space. Application is what you think for university and college. LinkedIn, most people thought it's a name of a prison, and big data was a good name for a rap star. This was only several years ago. Now they are part of our life, and there is no reason why this technology should not be part of our medical advances. What happened in technology is a syndrome called mashup. It's a new technology for stating a bifurcation lesion, or what is that mashup? Mashup is a definition of using different technology that was invented for other cause to a new cause. So where are the future opportunities in cardiovascular disease currently? We start with technology, and this technology is meshed up in order to meet unmet patient need. It's a mixture of fusion of different elements, and this technology came from multiple areas, not only the medical field, military technology, academic center, and together they are creating new technology to solve patient issues. So where are the future opportunity in cardiovascular field? I will touch base only on 3 areas: AI and big data, 3D printing, and remote medicine and robotic. When we, in the past, look at big studies, we actually create guidelines based on number of patients of less than 1,000. We do not see this number now, and you cannot create a good study or guidelines based on less than 1,000 patients, and that's create an area of a big data. We need to also remember that the way we treat our patient, the Framingham study, started in 1948, and at that time, the life expectancy in the United States, at least, was 65. The sample size was less than 5,000 patients, and we are still using the Framingham score in order to stratify the risk of the patient. What is machine learning and augmented human intelligence? It's initially used by non-medical field like Amazon, Netflix, Google. They predict customer behavior. If you choose a movie, you're going to get the next 5 movies that fits to your taste. Capable of analyzing large volume of data, can identify previous unknown association, things that you didn't think about. Established based on a machine learning-based financial trading company in the past, and bring to light hidden information within existing medical data that were not in the major hypothesis. So the major difference between machine learning and the way we use statistics is machine learning is the data-driven rather than hypothesis-driven. We used to look at data as a linear correlation between regression model. This is different when you have a machine learning. It's actually create 3-dimension relationship between new factors and the phenomenon. Enable us, instead of looking at 1,000 patients, to look at millions of patients and to connect these dots to see there's association between these phenomena. For instance, I'll give you an example. This is a study that was done several years ago that looked simply at serious CBCs in patients undergoing outpatient evaluation for multiple reasons. They were able to develop from simple CBC, age, gender, and smoking, prediction model of colon cancer for these individuals. And you can get, the patient get a flag in their chart or phone call saying, based on your serious CBC, you are at higher risk to develop colorectal cancer and you should be seen. This is large data analysis, and you can see the ROC of using this calculation. We did similar thing in our cardiac catheterization laboratory when we predict death from 100 days after PCI. This is a traditional logistic regression of regular factors that we use. But if we use large database and all the factors, you actually can identify population at risk, and you increase the prediction of event close to 0.9, just simply by using data and demographic information that is in the database of the patient. Other signals that are coming from our body can be used to assess disease. Not only our physical examination, other like the blink of the eyes, voice, face recognition. I don't know if you all remember the Frank sign that was published in the New England 1973, indicating that imaging of the ear and the crest is prediction of coronary disease. So our body sends us signals that can help us identify disease. I'll give you an example. This is a study we did here several years ago on voice recognition and voice element that can predict disease. So the voice is not only what you hear, it has a lot of frequencies. that can be associated with disease. In this patient, we looked at 150 patients undergoing coronary angiogram, and we had the appropriate control group. Patient have the voice recorded about 20-25 seconds. We have an AI algorithm to have voice signals and voice spectrogram similar to what you have in a DNA, and it has their own frequencies. Patient undergo coronary angiogram, and we were able to detect specific areas in the voice, specific frequency that were associated with coronary disease. And you can see in multivariate analysis, this is the detection of the voice of significant coronary disease prior to coronary angiogram with an ROC of 0.8. And as you can see here, this is a patient with coronary disease, and this is a control, significantly indicating that 2.6-fold increase in likelihood of coronary disease if you have this frequency in the domain of your voice. We then apply similarly frequency in the voice for the assessment of patient with heart failure to see if that's predict rehospitalization and event. So we have a prediction and training model like we do in AI with this voice of these individuals and identify acoustic feature extracted that were associated with event in this patient, and then we applied respectively. And as you can see, this is a Kaplan-Meier survival showing that the individuals with high level of biomarkers have lower survival and increased hospitalization. Interestingly enough, this was language independent, and some population in this cohort were speaking different language, and it wasn't different if they actually, because the voice recognized frequency and not necessarily the language. One of the mechanisms by which this marker is prediction event in heart failure is because it's associated with pulmonary hypertension that we show in a different study. So maybe pulmonary hypertension is associated with changes in the voice and prediction of event in patient with heart failure. Similarly, another technology using voice analysis to create depression and anxiety, some phenomena that we see more and more now with the social isolation and the elderly. We can have this device at home, recording their voice and have indication of this patient have anxiety or depression. Similarly, another technology of the voice, by recording the snoring or the voice at night, we're able to differentiate between snoring and mainly sounds of sudden death. So this technology of a simple device sitting next to your bed can actually create an alert if the noise, the breathing noise, are associated with risk for cardiac arrest. Again, voice that we used to think about has more element and more markers that we can identify disease state. We are now in the area of wearable decade. We have a lot of ECG patches, shirts, and that can record our ECG 24/7. However, ECG is not only the regular signal that we used to look at to detect myocardial ischemia. I'm sure you're going to have other talks on this area, but just briefly, this is a study that was done here by Dr. Attia and Friedman using ECG, using AI and technology to detect by ECG the degree of the ejection fraction. As you can see by ROC of almost 0.93, they were able to predict if this patient has a low or high ejection fraction based on the analysis of the domain of the electrocardiogram signal. Just to remind you that other tests that we use, like a mammogram, cervical cytology, and PSA, have a lower AUC compared to the detection of ECG of ejection fraction. Similarly, you can use also to classify the patient of prediction of disease before it can manifest. If the patient has this signal still with normal ejection fraction, this patient may have a chance to develop low ejection fraction in the future. Another features that we can detect from the patient without actually touching the patient is two of them that I will just mention. One of them is the fundus photograph that can detect coronary artery disease risk factors. And recently paper that came several weeks ago showing face recognition to detect coronary disease. The deep learning to detect coronary disease based on facial photos. And you can see here the prediction of coronary disease based on face recognition. So a lot of signals coming from our body, voice, ECG, that's electricity, fundi, and face recognition that can help us detect disease, and specifically in our interest, coronary artery disease. So potentially when you have a patient in the hospital, you can open your electronic environment and you will get automatically some alert, like if the hemoglobin drop on the last several, you can have an alert of colonoscopy, or ECG can give you an alert that you need an echo, and voice analysis can give you alert on coronary disease and heart failure. Just to look at the implication of that and the dangers of using imaging, this is a study published several years ago, training pigeons that have a similar eye mechanism as human to detect histology for breast cancer. And as you can see, with the high ROC, these pigeons that were trained to look at histology photos were able to use mammograms and histology to detect breast cancer. And if you use two pigeons together, then it increases the detection. So just reflect that not only human eye can actually be trained to detect disease based on AI. Let's look at 3D printer. We used to look at 3D printer as teaching and training, that we use models for the surgeon and the intervention in order to have the map road of what they're going to do and have a specific modeling of the patient. We are actually launching a project in the last several years looking at 3D printing it together with cell administration to patients with heart disease as well as aortic stenosis. As we can see, this is a high prevalence disease. This is our model now. The patient with the animation of a patient with aortic stenosis, severe calcified aortic stenosis. We will do a specific imaging of this patient valve and heart to have individualized. We're going to create a 3D model of this aortic root and aortic valve for this patient. We will take cells, mesenchymal cells from this patient, and we're going to feed this to the model into a 3D printing, hopefully to print a specific and individual valve in this patient based on their own cells and matrix. Following the printing of this valve, we'll be able to mount it on a stent like we do in TAVR, deployed it in the aortic position. This is a work in progress, but other groups and our groups are currently working on it. Lastly, since we have difficulty currently have direct access to a lot of the patient from a lot of reasons distance, we need to develop methodology to treat and diagnose this patient from a distance. I already mentioned to you AI and other features. This is a map showing the equalization to care in the world. And you can see most of the places in the world do not have access to medical care. It anticipated in the United States a shortage of 90,000 physicians until 2025, limiting access and explaining the heterogeneity in morbidity and mortality among population. For instance, this is the distribution of cardiologization laboratory in the United States. There was a growth, but the growth was in the same area. And the procedure growth and access grew only by 1%. So even in the United States, there is a major issue in access to cardiologization laboratories, patient coming with ST myocardial infarction. Even in Rochester, we have sometimes bad weather and ice on the road that prevent the patient even to get from the area here. The helicopter cannot fly and the ambulance cannot drive to bring our patient to our emergency room to have an emergency coronary angiography. We all now have a lot of technology to help robotic instrument in our life. We have a car that is driven without a driver, and we have robot, and we have even a device cleaning our house. Why not to apply this technology to the way we take care of the patient? We're talking now robotic in the cath lab. The robot in the cath lab, or the robot arm in the cath lab, is currently exist and approved for use. But their major goal was actually to have the interventionist sitting in a cockpit here, operating it from the main cause of reduced radiation and the need of the individuals to wear a lead because of back pain and other side effects. So this system is already exist, and it's in operation. A precise robot control. You can control the guide, the balloon, the stent, radiation shield, and you actually have nice visibility of the case. This is currently already existing, approved. And you can see the robotically assist PCA, reduce contrast, fluoroscopy, radiation. We thought maybe it's a good idea to apply it remote, to turn this robot remote. And if we can operate a vehicle from US to the moon or to other stars to Mars, why can't we operate an arm of a robot to help us perform PCI in the distance? The major issue, of course, delay in the time that cannot be tolerated in NASA, cannot be tolerated in cath lab, of delay of 20 minutes. We worked together with several foundations to create a better way to have a delay time, to reduce the delay time between the cath lab and the operator, and slowly moving the operator away from the catheterization laboratory. In the first case that was published, we actually presented in TCT several years ago the coronary angiogram and PCI of an animal done at Mayo from far away. This was the cath lab, and this was the animal lab. This was several miles away. And the operator was able to perform a complete coronary angiogram and PCI just using with his suit and tie in the cath lab where the animal was here. Several months later, we participated in the first human live demonstration in India, 22 miles away, and you can see the operator was sitting here in his office, performing coronary angiogram on a patient and PCI in 22 miles away. I have to emphasize that the distance does not affect the delay time as much as the relay time in the cable infrastructure. So you can, if there is a good relay station, you can do in a good relay time the angiogram later on. This is a drone that is used to provide assistance in the case of cardiac arrest. This is another use of modern technology to help individuals deliver medical care without the need to ambulance to drive and stuck in traffic. This individual had a cardiac arrest in the shop, and the device was delivered by a drone with instruction online how to operate it. I show you several technologies, and I just want to give some caution that this is the natural history of evolving therapy. You have a progress, you have excitement from a new technology, and then you start looking at this and you have a reality check that puts you into depression, and then you put things into perspective. So new technology, not all of them are going to work. Let me finalize with a movie from 1966 that already predicted that. This is The Future is Here, a fantastic voyage. And they actually thought at this time to create a small shuttle that will be injected to the human body. And you can see this little shuttle here going through the bloodstream. You can see the red blood cells, and you can see some white blood cells getting close to that, recognize it as a foreign body. And these little, you can see here through the blood vessels, this is a normal endothelial cells, and the little ship is going through the blood vessels, getting close to the heart, getting dangerous from the closure of the valve, and getting area in the heart that actually have disease. And they potentially, in order to cure that, they are getting out of the shuttle and burn this area, maybe doing ablation, who knows, and treating these patients. So this was in a movie in 1966, many years ago, and it might be that we are very close to this technology currently. Thank you for your attention. Hello. Can you hear me? Hello.
I can hear you, Amir, but I'm not hearing anything from the podium.
Me neither, but I think I
Yeah.
can hear you.
I sent them a message. Excellent talk. Wonderful. Thank you. Thank you.
Oh, did you?
I saw that movie.
Oh, okay. Yeah, it was a long time ago. Did the talk go okay?
Yes, excellent. The audio was low, but once I turned my volume up, it was perfect.
Okay.
Yeah, perfect.
Я благодарю профессора Лермана за великолепную презентацию современных возможностей в кардиологии. Это совершенно изумительно. Но я хотел бы задать вопрос относительно самой актуальной проблемы, которая сейчас есть в кардиологии. Это терапия больных с сохраненной фракцией выброса. Что вы думаете по этому поводу, о безуспешности терапии этой группы больных?
Tom, did you understand what's going on?
I do not. I heard there for a little bit, but the podium mics aren't working or transmitting when they...
Yeah, but I heard something. I don't know. They said about. I don't know. Oh, we'll wait. We'll wait.
We'll wait. Yes. Hugo, are you hearing anything? Mike, you have to unmute. You have to unmute your mic. I can't hear you.
Okay. Can you hear me?
Now, there you are.
Now we can hear. Yeah.
Yeah, I can hear you, but I can't hear them, right?
No, I can't hear them. No, I just briefly heard the podium for half a minute, but it stopped again. Yes.
Right. When the guy came walking up, he must have had a hand mic or something, but podium mic's not working.
They may have still some questions in the room related to the first presentation. I could imagine when the guy walks around with the microphone here.
Yes, that microphone's working, but the podium mics are not working.
Mm-hmm.
Okay.
So we just wait and see what happens. How is Corona in your area? Is it is your hospital pretty full with that, or not too much?
Not too much.
Not here. The state of Minnesota has cases, but Rochester we're not by any means inundated. Enough cases that I'm not allowed. It's my grandson's birthday today in New York City, but New York won't let me in because we have too many cases in Minnesota.
Okay.
Yeah,
so I have been working with Jesse Edwards many years ago. You may know him.
Okay.
Yeah.
I think we know him. Yes.
Yeah. So and Howard Burchell also. So it's a long time ago.
Those are names from the past.
Yes, I have been in Minneapolis about 40 years ago as a research fellow. So, and then I went to the Mayo Clinic several times.
Они нас не слышат. Нет, они нас не слышат. Hugo, can you hear me?
Yes, I can hear you. Yes.
Professor Lerman, do you hear me?
Yes, I do. I can hear you.
First of all, I had feeling that you didn't hear what I was talking about.
No, we just now started hearing you 1 minute ago. I sent you some messages.
Замечательно. That's great. Amir, first of all, I would like to thank you for both presentations. And they were both brilliant. And now we had feeling that we looked into future with the second one. And the first one was very important from the practical point of view because And following the first presentation, we have a question from the audience. And can we ask the question?
Sure. Yeah, I'm here. Yeah.
Вот задайте еще раз, пожалуйста.
Мой вопрос состоит в том, что думает профессор Лерман относительно безуспешности терапии больных с сердечной недостаточностью и сохраненной фракцией выброса.
Не слышно. Опять
No, you may have to translate the question.
Yeah.
Can I tell the question instead of our professor? The question was the following. What do you think? Да, озвучьте, пожалуйста. What do you think about treatment of patients with heart failure but with preserved ejection fraction? What is your opinion, your point of view in regard to these patients? Do you have some special attitude towards this?
Yeah. So I think heart failure with preserved ejection fraction, it's a heterogeneous disease and it has multiple mechanisms. And I think the first step is to make the right diagnosis for the mechanism. Based on that, we can design treatment. So some of the patients with heart failure with preserved ejection fraction have significant underlying coronary disease. So first of all, if they do by an angiogram, then intervention should be indicated. In patients that do not have significant obstructive coronary disease, here at Mayo, we do a combined exercise test in the cath lab with right side catheterization, followed by microvascular function assessment. Because there is at least 25–30% of the patient with heart failure with preserved ejection fraction that have underlying microvascular disease. And there are several reports of that from other groups and ours. If this is the case, then we need to address the underlying mechanism of microvascular disease with medication such as ARB, or renin, from the group of the ARB, the ACE inhibition, as well as treatment of microvascular dysfunction with statin, calcium channel blocker, and alarginine. So I think now we make a diagnosis of heart failure with preserved ejection fraction based on increase in wedge pressure during exercise. So we would like to exercise all these patients with the right side catheterization to see, because there are a lot of patients that have normal pressure at rest, but significant increased pressure with exercise. So in summary, first of all, the right diagnosis. Is it ischemic? Is it non-ischemic? Is it obstructive or non-obstructive? Reduce, if there is microvascular dysfunction, we aggressively treat the blood pressure, other risk factors, exercise program, and some other medication like aldosterone inhibitors that came up to see some. Now, I do think that the SGL2 inhibitor drugs may have a potential, and there are ongoing studies addressing their effect in heart failure with preserved ejection fraction. Did you hear me?
Thank you very much for your answer. We know that I know that you are very short of time. I have only another question, if possible.
Yeah, I have time now to answer.
What is your impression and your explanation of the phenomenon that in many countries the myocardial infarction rates went down in the period of COVID-19? What is your opinion? Why it happened?
Okay. So that's a good question. And I think that we need to differentiate between their heart myocardial infarction incidence went down to whether they actually presented with that to the emergency room. What we're actually observing is patient not coming to the emergency room when they have chest pain because of a concern of coming to the hospital and the infection, rather than decrease in MI. So we did a study where we actually, in the United States, where we actually use the engine of Google to see if people are searching for the words infection, chest pain, and heart attack. And we did not see a decrease in the search during the COVID pandemic of people searching for this word in Google. We previously shown that people immediately, when they have chest pain, they don't call 911 or ambulance. First of all, they go to Google to ask the question. So we did not see any decrease in actually searching, patients searching for chest pain or heart attack. I think what happened is that they do have, I don't think that there is a decrease in myocardial infarction. I think there was a decrease in presentation to the emergency room with chest pain, secondary to the concern of coming to the hospital. Did you hear me? Is that okay?
Thank you very much for your answer. Thank you very much once again. Brilliant presentation.
If you have more
we have to think over it. Many years ago, it was fantastic to have a phone in your hand. You couldn't believe it will be reality. But now, when you speak about this, using of face or voice for diagnostics, it's also impression that it is fantastic, but maybe it will come in our lives. Once again, thank you.
Thank you very much. If there is one more question, I can still entertain it if you have one, but if not.
Еще есть вопросы? Everybody are so much impressed, really, if you look.
I hope that I will be able to come and visit you soon.
Thank you very much.
You're welcome. Thank you very much. Bye.
We want it very much. You are mostly welcome, and
next year
we will organize the visit of Mayo Clinic group for sure in next year.
Next year will be good. Hope you're all going to be healthy and safe. Thank you.
Так, ну, давайте следующее.
У нас...
Давайте объявим вот на связи профессор Аллисон.
Ага, Томас Аллисон, да. Помимо протокола Брюса, следующее сообщение. Томас Аллисон, это тоже клиника Мэйо. Пожалуйста, подключайте нашего докладчика.
Все-таки вот это
Здравствуйте,
сложности, да.
and welcome from Rochester, Minnesota. First, let me say how pleased I am to be participating in this 75th anniversary conference. I thank the organizers for the invitation, and I'm very sorry that the infectious disease events of the world have prevented me from coming to Moscow in person. So I'm giving two talks on exercise testing. The first is entitled Beyond the Bruce Protocol, and this is going to focus on sports and exercise cardiology. Now, of course, there's a very complex and deep interaction between cardiovascular disease and exercise. Prevention, symptom presentation. Today we'll talk about diagnosis, treatment in cardiac rehabilitation, and the risk of exercise in sports cardiology. And that will be somewhat of our focus today too. I have no disclosures other than to say I have done a lot of exercise in my time. I was once a runner. You can see me off in the corner here in the twilight of my running career with some other famous American runners, Bill Rogers and Frank Shorter, who finished a little bit ahead of me in this race, but that was a long time ago. So exercise testing in most centers means putting the patient on a treadmill and exercising the patient according to the Bruce protocol. Now, it's interesting that the Bruce protocol was not really thought out and planned, but rather the original treadmill used had a transmission, and the Bruce protocol represents the speeds that could be produced by that transmission. Now, generally, though not exclusively, Bruce protocol tests are done with accompanying imaging these days. Now, we do a lot of Bruce protocol tests here. We did about 20,000 stress tests last year, and at least half of them or more were on the Bruce protocol. But we also do more interesting forms of exercise testing here in Rochester. Besides the treadmill, we have 8 different ergometers that we can use for exercise testing. Now, sports cardiology involves providing cardiovascular care to competitive athletes and other highly active people. Key elements of sports cardiology include the differentiation between exercise-induced cardiac remodeling and cardiovascular pathology. It also involves the evaluation of the symptomatic competitive athlete or the highly active person, and this usually involves some exercise testing. Now, in that exercise testing, we are trying to reproduce the symptoms of concern, and we're trying to, as much as possible, mimic the sport or the work activity. My first case study is a 44-year-old male endurance athlete. He complains of fatigue during cross-country ski races, and he is training, or was training at this time, to compete in the American Birkebeiner 50-kilometer freestyle cross-country ski race. This patient has no cardiovascular disease history, no coronary artery disease risk factors, and he presents with a normal cardiac exam. Now, here's an example of what happens to him. In a recent 58-kilometer ski race, he was with the leaders at 12 kilometers. 35 minutes into the race, he began to fatigue. He struggled starting through the remainder of the race, and his time of 3 hours and 22 minutes represented a 59-minute deterioration from the previous year. He had a cardiac workup approximately 1 year prior to seeing me. That included a normal echocardiogram, a normal exercise test on the Bruce protocol. In fact, he went for 16 minutes. He had a cardiac event monitor showing entirely normal tracings. This was his peak exercise electrocardiogram from the prior year. His heart rate is 171 beats per minute. He's in sinus rhythm except for a few premature atrial contractions, no ventricular contractions, no ST segment changes. So how do we evaluate this gentleman? Well, we constructed a special exercise test for him. It was a non-graded test to simulate race conditions. We started at 7.5 miles per hour or 11.2 kilometers per hour with a 5% grade. And after 25 minutes, we increased to 12.8 kilometers per hour at the same grade. 34 minutes into the test, he developed an irregular heart rate with, an irregular rhythm with a heart rate of 206 beats per minute. We let him slow down to walk. Sinus rhythm returned. The arrhythmia resolved. But when he began running again, he immediately went back into this irregular rhythm at the rapid heart rate. So, of course, this is atrial fibrillation. The loss of atrial kick, the rapid heart rate with reduced diastolic filling, these deteriorated his performance and were responsible for the 59-minute slower time than the prior year. Now, there's a low medical burden of atrial fibrillation in athletes, but it interferes with their sports. We did a short trial of flecainide, but he had recurrent atrial fibrillation on flecainide. Arrhythmias in cross-country ski racing has been previously reported, both atrial fibrillation and symptomatic bradyarrhythmias. And as you can see here, the fastest runners, the runners or skiers who competed the most races had the highest risk of atrial fibrillation and bradyarrhythmias. As it turns out also, the faster runners and faster skiers had more atrial fibrillation and more bradyarrhythmias. The patient had a strong desire to continue with his competitive sports. He was a runner in the summer, a skier in the winter, and so he underwent a radiofrequency ablation of atrial fibrillation. This included left atrial pulmonary vein, wide area circumferential ablation, and cavo-tricuspid isthmus lines were created. Here you can see spontaneous left superior vein firing with a block to the left atrium. No atrial fibrillation was triggered. He sent a note to his EP doctor. I just performed the stress test. I didn't do the ablation, obviously. And he said, I have to send a note to my favorite doctor of all time, saying that I finished well up into the elite wave in the Berkey this year, a really fantastic result for someone of my age and limited training time. He's a medical researcher here at Mayo. Not all athletes earn trophies. So now we're going to look at a second case of what is called a highly active person. And these individuals also fall under the guise of sports cardiology. So our case study is a 34-year-old man. His work requires an annual electrocardiogram. He similarly has no history of cardiovascular disease and is entirely asymptomatic. He's a highly active person. He's a civilian worker at a military base, and I'll give you more insight into this later. Now, what does he have here? Of course, he presents with left bundle branch block. Now, as I said earlier, distinguishing exercise-induced cardiac remodeling from cardiac pathology is an important aspect of sports and exercise cardiology. These are the Seattle criteria. There are a number of findings that would be considered, such as a Winky block, that would be considered normal adaptation to endurance exercise. But complete left bundle branch block is considered an abnormal finding and requires further evaluation in all cases. Okay. Again, the Seattle criteria suggests that a left bundle branch block cannot be produced normally by any type of exercise training. It will not resolve with hiatus from exercise and requires an assessment of left ventricular function and a search for the etiology of the left bundle branch block. So there was no clear etiology. He had a negative coronary CT. His initial ejection fraction of the left ventricle was 30% by echo, and we would consider this stage B heart failure. He's asymptomatic, but he has underlying structural disease. Guideline-directed medical therapy includes a beta blocker, and he received carvedilol with an improvement in his ejection fraction to 46%. Angiotensin receptor blocker was added. EF improved further to 50%. We performed a cardiopulmonary exercise test. We don't exactly use the Bruce protocol for this type of test, but it's very similar. It's graded exercise with discrete stages lasting 2 or 3 minutes, progressing toward maximal exercise and subjective fatigue. So this gentleman exercised 12.7 minutes. He was limited by general fatigue. He achieved 87% of his predicted heart rate despite being on the carvedilol. He had only 1 PVC. He had a good blood pressure response, and his peak oxygen consumption was 38.5 milliliters of oxygen per kilogram a minute, 90% of predicted for age, or an actual 11 METs. He also had a normal breathing efficiency, which we measure by the VE-VCO2, and I'll talk more about that in my heart failure talk. In any case, he doesn't have any evidence of heart failure based on this exercise test. He had a left bundle branch block, so we can't diagnose ischemia, but we know from his CT angiogram that he does not have any coronary artery disease. So we ask ourselves, can this gentleman return to work? Well, why not? He has no evidence of coronary artery disease. He's asymptomatic. His exercise tolerance is relatively well preserved, but here's his work. He's a hazmat worker at this military base. He wears a level A hazmat suit. He's sealed in a gas-tight, vapor-tight, splash-resistant suit. The weight of the suit and the accompanying equipment, 19 kilos. He has a positive pressure, self-contained breathing apparatus within the suit, chemical-resistant inner and outer gloves, chemical-resistant footwear with steel-toed boots, and puncture-resistant midsole. He wears long underwear and a hard hat under the suit. It's a very hot and humid environment. Within the first minute in the suit, the oxygen concentration drops below safe levels to 19.2%. At 20 minutes, it's down to 16.3%. Should the breathing apparatus fail, he has approximately 5 minutes of breathable air in the suit, but the oxygen concentration of that breathable air will reach 11 to 12% by 5 minutes. The National Institute of Occupational Safety and Health studies suggested work time is reduced 56% in the suit. So how to evaluate? Well, let's put him in the suit and let's put him on the treadmill. So he exercised 11 minutes on our Mayo protocol, which is very similar to the Bruce protocol. He reached 3.4 miles per hour with 18% grade, achieved 11 METs, a peak heart rate of 157. We continued him at a slightly reduced workload for an additional 5 minutes so we could reach the prerequisite internal suit temperature, 104 degrees Fahrenheit or 40 degrees Celsius. He tolerated the exercise well. He was released to return to work. At 4 years follow-up, he's doing well. He's had no cardiovascular events, and his ejection fraction is still about the same, 46% by cardiac MR. So here are my take-home points from this presentation. Sometimes we must design special exercise tests that are sport or work specific. In other words, we must go beyond the Bruce protocol in evaluating these special patients. Second point, the evaluation of the competitive athlete or highly active person requires special skills. You need to understand exercise-induced cardiac remodeling and understand the cardiac demands of the sport or work activity that the patient is participating in. And finally, cardiovascular disease, such as each of these two gentlemen had, does not necessarily disqualify a competitive athlete or highly active person from high-level activity, but appropriate management and periodic reevaluation are necessary. So I thank you very much for your attention. Be happy to entertain any questions or comments.
Professor Allison, thank you very much for your presentation. The presentation is open for discussion, коллеги, будьте активны, задавайте вопросы. Да, пожалуйста.
Yes, thank you.
Thank you very much. Does it mean that this exercise test is incapable to predict lesions that may occur at maximal exercises?
I didn't completely hear that. Sorry.
Еще раз повторите. Не расслышал он вопрос.
The audio was a little blurred.
From your presentation, it follows that exercise test, usual exercise test, does not capable to predict these cardiac pathologic changes that may occur at maximal exercise.
Yes, that's correct. When we think about most sports or hard work activities, they really don't involve slowly progressive walking up a hill. You know, they're bursts of activity, more prolonged activity, higher intensity activity, combination of leg activity or a combination of dynamic and static exercise. And so we have many cases like this where patients have a normal Bruce test, and then when we alter the protocol, the abnormalities jump out at us. Now, of course, exercise testing will not always detect the problems, and so we have wearable monitors and actually injectable monitors that the patients can go out actually in training and competition, and perhaps we make the diagnosis that way. But we try to get it in the laboratory if we can. Sometimes this may again involve, we often have patients exercise, run 10 miles before they come in for the stress test to more simulate longer types of performances and things. Again, you talk to the patient and try to get a very specific evaluation. Doing push-ups, lifting weights, other things like that, or kettlebells, we sometimes do those. We have a rowing machine we can bring in the laboratory to evaluate the patient.
Thank you very much for your answer. Now, Tom, I have a question. Did you change something in stress testing in this period of COVID-19? Some people write that stress tests should be minimized because of danger connected with personal. What is your opinion in this regard?
Yeah, very, very interesting question. And I have a paper now that I'm submitting tomorrow on this subject. But what we did, initially we curtailed stress testing, and then we reopened the laboratories. We're doing 40 to 50 stress tests per day. And we have installed an air recirculator in the laboratory. So I don't know if I can maybe quickly get to this if you want, show you a picture, but we studied exercise tests in a sealed tent so that we could measure aerosol production during exercise. And we found if we put the air recirculator right in the face of the patient exercising, all the aerosol disappeared, went through a HEPA filter, and virtually none of it went out into the room. So patients are screened for COVID before the stress test. I don't know that that's really necessary, but it's an institutional policy. The person performing the test wears an N95. The patient exercises with the air recirculator in place. And I'm going to real quick try to bring up a picture for you. Pardon for seeing these other things here, but let's come up with. It might take too long, but I'll find this. I will find the picture and I will share it with you at a subsequent at my next talk. I'll pop the picture up quickly. So we're back pretty much in full capacity. Okay, I can't hear you now, but Nana.
Хорошо,
Okay.
спасибо. Я говорю, будем ждать картинки. Это очень действительно интересно, потому что многие европейские... Вы переводите ему? Нет. It is really very interesting because many European leaders came to conclusion that these tests should be minimized, or maybe better to make stress tests with some pharmaceutical agents with medications, but not with physical activity, which is dangerous for personnel.
Yeah. Well, we agreed with that assessment, but we measured aerosol production, and we confirmed that we could mitigate the aerosol. By the way, masking, while masking works very well in social settings where people are just talking and breathing, when you exercise, the air doesn't, as you're ventilating at 100 liters a minute, 100 liters a minute doesn't go through the mask. It goes around the mask and off into the atmosphere. So the patient wearing a mask is not the answer. One must regulate, just like in the hospital isolation. We basically create isolation, air isolation in the exercise lab. So I'll show a picture at the beginning of the next talk so people can see what we're doing.
Thank you. Thank you very much, Tom. And we move to профессор Саннер. Hugo Саннер.
Hugo Саннер, кардиореабилитация, европейский взгляд, Берн, Швейцария.
Dear colleagues and friends, it's an honor and pleasure to be part of an important event, also not in person, but just by video conference. First of all, I would like to congratulate the 75th anniversary of the Russian National Cardiology Research Center, and my congratulations come from the Institute of Social and Preventive Medicine of the University of Paris. It is a partner institution of your research center. The picture you see is from the signing of the official collaboration agreement by Professor Franco and Professor Pogosova. Before we start, we have to be aware of what determines our health. We agree that 50% of our health is determined by healthy behavior, about 20% by the environment, 20% by genetics, and only about 10% by access to healthcare. But when we look at what we spend on being healthy, 88% of the expenses are made for medical services, and only a few percent for health behavior. We know that there are several risk factors to be associated with atherosclerotic disease and myocardial infarction. And this data comes mainly from the Interheart study from many countries around the world. The lipids and smoking, diabetes, hypertension, abdominal obesity, psychosocial risk factors being the leader, and all is about the atherosclerosis. So these risk factors lead to deposits of cholesterol in the vessel wall, and in the acute event to rupture of the endothelium and thrombus formation. The mediator for these events is inflammation. Therefore, the target systems of cardiovascular rehabilitation and prevention are the endothelium, the clotting and coagulation system, and the autonomous nervous system. And inflammation, as I said, is the mediator of the development of the plaque and in particular of the rupture of the plaque. There is clear evidence that there is an association between recurrent events and lifestyle habits. In this OASIS 5 trial, more than 18,000 patients from 41 countries have been included, and they reported adherence to diet, physical activity, and smoking cessation. And we have information about the medication and studies looking at cardiovascular events and all-cause mortality at 6 months. And the risk of myocardial infarction after 6 months is reduced by 43% when quitting smoking, by 48% with diet and exercise adherence. And if the patient is a persistent smoker and non-adherent to diet and exercise, he has a 3.8-fold risk increase for myocardial infarction, stroke, or death after an acute coronary syndrome. What can we do to help the patient to be free of recurrent events and to stop the atherosclerotic process? It is important to recognize that there is no scientific evidence for significant positive long-term effects of counseling in regard to morbidity and mortality. There is clearly no light version of cardiac rehabilitation. We need a comprehensive team approach to really target the lifestyle factors, including nutrition counseling, physical training, smoking cessation, psychological support, and optimized medical treatment. There is convincing evidence from large studies demonstrating the effects of multidisciplinary cardiac rehabilitation in coronary patients. These are the largest studies so far, looking at the different patient population. The first one, PCI patients, follow up to 10 years. The second, coronary artery bypass grafting patients. The third, from Martin et al. On coronary artery disease patients, follow up to 14 years. One after acute intervention for acute coronary syndromes. In total, more than 45,000 patients, follow up 4 to 14 years, and reduction in mortality 35% to 47%. I would put a specific emphasis on the fact that if you include patients after PTCA also for stable and not only for acute angina and acute coronary syndromes, mortality can be reduced by up to 44% when patients attend a cardiac rehabilitation program. However, the outcome is clearly related to attendance. This is a very large study from Canada where they looked at the difference in events and compared cardiac rehabilitation completers, 49%, with non-completers over a period of 13 years. And if you look at those attending cardiac rehabilitation, they have a huge benefit in regard to risk of death, risk of all-cause hospitalization, and cardiac rehabilitation, cardiac event. Therefore, in summary, we see that cardiac rehabilitation is the most underused evidence-based intervention and therapy in cardiac care. However, to have evidence 1A for coronary patients and 2A for patients with peripheral artery disease, it has to be exercise-based, it has to have a minimal duration and a minimal number of sessions, and it has to be multidisciplinary. Nevertheless, we know that there are many barriers to implementation of cardiac rehabilitation, and that attendance is not as we would like to see it. Barriers are age and gender, particularly elderly patients and women do not attend cardiac rehabilitation to a degree which we would like. Disease severity, comorbidities, motivation by patient and physician, coordination of the system, socio-economic factors, travel distance, and resources are important barriers to implementation. Now, we know a key factor to overcome these barriers is automatic referral. It is no surprise that there is intense research looking at alternatives to residential, stationary, hospital-based rehabilitation. And one alternative is home-based cardiac rehabilitation. And this study compares clinical and cost effectiveness and benefits compared to residential, stationary, hospital-based cardiac rehabilitation, and they found no significant differences on physical fitness, physical activity level, or health-related quality of life between the two types of cardiac rehabilitation. However, patient satisfaction was higher with home-based training. Another alternative to center-based rehabilitation is using the smartphone for lifestyle-focused text messaging on risk factors. And this study, like many others, found greater improvements of cardiac risk factors compared with usual care. Using mHealth for behavior changes for cardiovascular disease self-management, this systematic review shows that mHealth has the potential to change lifestyle behavior. However, up to now, results are still limited and inconsistent. We see a great chance to help patients to improve their lifestyle by lifestyle monitoring using the smartphone. We can track smoking, physical activity, eating, and stress, and can use this for advice to increase motivation and adherence to the program. This is used in primary prevention, secondary prevention, and cardiac rehabilitation. And we should not forget the importance of social media, because we are looking forward to the generation digital. Everything will change, and in the future, patients may inform the community about the course of their heart attack, like this patient back home alive, let's celebrate with friends. It is general consensus that smartphone support is very important and will be even more important in the future when the digital generation is growing older. And the general consensus on that is that smartphone will become the ultimate health hub for healthy and diseased persons. When we looking at what is new in regard to information about cardiac rehabilitation, we have 3 position statements from the European Association for Preventive Cardiology from this year 2020. One dealing with secondary prevention through comprehensive cardiac rehabilitation from knowledge to implementation. One position paper dealing with standardization and quality improvement, and one position paper on cardiac telerehabilitation in the COVID-19 pandemic. Let's summarize briefly what is new from these position papers. From the first one, it added new challenging patient populations like TAVI, mitral valve click, ICD, LV assist device, cancer patients, and non-adherence patients. New treatment targets have been formulated according to the new guidelines. Optimal training intensity, definition has been updated in regard to endurance, strength, resistance, and inspiratory muscle training, particularly for patients with heart failure. For the first time, multi-component interventions for elderly frail patients have been defined. There is a special emphasis on high-intensity training for heart transplant patients. And indications for cardiac rehabilitation have been extended to patients with peripheral artery disease. There is emphasis on resistance and strength training for diabetes patients because this type of training has a particular beneficial effect for diabetes patients in regard to glucose control and weight control. More emphasis is on psychosocial risk factors and return to work, and there are some tools which could improve adherence to cardiac rehabilitation. The second position paper on standardization and quality improvement offers minimal and optimal structure-based cardiac rehabilitation metrics defined by the European Association for Preventive Cardiology Accreditation Program in regard to infrastructure, human resources, and center requirements. The third, telerehabilitation in the COVID-19 pandemic. The content is an update of recent telerehabilitation studies and includes practical guidelines to set up a comprehensive cardiac rehabilitation program. The use for telerehabilitation in COVID-19 patients, advantages of using telerehabilitation under these circumstances include greater privacy. You can offer the program at one's own pace and time. There are minimal travel and transportation barriers by using telerehabilitation. We can offer higher patients' independence. We can combine telerehabilitation with telemonitoring. We can protect the patient from virus infection. And we can provision core components of core common components at home. We can tailor the program as good as possible to the patient and all at low cost. Action points to improve the usability of telerehabilitation are digital literacy, reimbursement is not secured, the integration in the electronic medical record is not guaranteed, we have less face-to-face interaction, data safety and privacy is a problem, there is a lack of legal principles and a lack of social interactions. However, we think that telerehabilitation has a great future and great advantages under these circumstances. To summarize, we have 3 new position statements in 2020 from the European Association for Preventive Cardiology in regard to cardiovascular rehabilitation. And for those who are active in this field, I strongly recommend to read these papers and follow the recommendations. Overall, we know that interventional cardiology is very important and very effective under many circumstances, but we should not forget to send patients to cardiac rehabilitation according to their possibilities and the availability of programs. What we certainly want to avoid is a situation like for this patient, he received 67 stents. You can see on the picture almost full coronary arteries there are stent placements. He has also an internal defibrillator and had bypass surgery. So let's help our patients to avoid such sad and also costly situations. With this, I end and wish you all a good proceeding of the Congress. Thank you very much for your attention. Hello, Nana, I cannot hear you.
Thank you very much, Professor Sanner, for your excellent presentation, very comprehensive and looking also into future. And today we heard two presentations focusing on mostly technologies and new possibilities of modern technologies in cardiology, and it is really very interesting, and we hope that we will see in our life implementation of all these techniques. There are some problems. I don't know why I don't see our lecturers, our distinguished colleagues. We have some there are some technical issues which our technicians cannot solve. We have seen the lectures very well and hear everything, but there is no picture now.
Hello, but can you hear me?
Can you hear either of us?
Can you hear me?
Now we have you on the screen. Thanks again.
So it shows us we still may need to take the patient into the lab. Sometimes the remote technology, if we can't see the picture, and I'm just teasing here, if we can't see the slides, it's hard to do the angiogram.
Mm-hmm.
That's true. It's better to be in person and not on distance, so big distance.
If you would like, if you let me share the screen.
Anyway,
Okay, go ahead.
Anyway, very, very many thanks. Hugo, коллеги, есть вопросы? Профессор Саннеру есть вопросы? We know Professor Sanner very well because we knew him numerous times, came to our center and to our country. He is Professor Emeritus of Sechenov University. So it's great to meet you once again, and let me conclude this session. It was really very, very interesting. Thank you so much for joining us. Thank you, and see you in Moscow. And Tom, we will see you in the next session.
Yes, okay, good. I have those pictures of the laboratory that we've created. If you want to see them, let me know.
Да, конечно. Yes,
Yeah.
of course.
До свидания for a while. Huh?
Bye.